Welcome, Australian practitioners, to our webinar. My name is Dr. Narala Jacobi. I'm the Chief Medical Officer here at SIBO Test. Many of you are probably busy calming your anxious patients and will listen to the recording later. So I hope you stay safe in these precarious times, and thank you so much for joining us. Let me get straight to it. Dr. Pimentel's presentation is followed by a Q&A, and I will conclude the webinar by giving you the information on the logistics of the test in terms of cost, ordering process, etc. SIBO Test is absolutely thrilled to have the opportunity to offer the IBS-SMART to our Australian practitioners. And if you've heard me speak at conferences or have taken some of my educational courses through our other site, the SIBO Doctor, you have probably heard me mention both Dr. Pimentel as well as this blood test, the IBS-SMART. I've known him now for almost 10 years, and I'm always impressed with his forward-thinking and truly brilliant medical mind. Dr. Pimentel is a gastroenterologist, professor of medicine at the Geffen School of Medicine, and associate professor at Cedars-Sinai Medical Center in LA, California. He's very busy right now with preparing his hospital for the pandemic. But active in research, Dr. Pimentel has served as a principal investigator or co-investigator for numerous basic science, translational, and clinical studies in such areas as IBS and the relationship between gut flora composition and human disease. His work has been published in numerous prestigious medical journals. A few of Dr. Pimentel's most significant accomplishments include the discovery of rifaximin as a treatment for irritable bowel syndrome. He also developed the very first blood test for IBS on the basis of IBS being derived from acute gastroenteritis, and this is what we'll be talking about today. He also has described the association between IBS and bacterial overgrowth, or SIBO, and uncovered the methanogen Methanobrevibacter smithii as an agent for causing constipation in humans. So he's been so instrumental in many of the understandings that we have about SIBO. So without further ado, welcome, Dr. Pimentel.
Narala, it's a pleasure to speak to all of you down there, and I know that in this sort of strange times we're in across the globe, it seems ironic we're talking about irritable bowel syndrome, but despite what's going on, people still suffer. So I think we need to carry forward what we're doing and continue to educate around this disease, but putting it into perspective with what else is going on. So I thank you for taking the time tonight, and I wish you all the best, and take care of yourselves down there, and also please take care of Tom Hanks while he's there as well. So irritable bowel syndrome affects about 40 million people in the US, nearly 1 billion worldwide. So in essence, it is the most common GI disorder, but also the most expensive GI disorder. And one of the reasons it's so expensive is not because we do colonoscopies in these patients or we do a lot of testing, although that is the reason. The main reason it's so expensive is because we have no diagnostic test for IBS. We've relied on the Rome criteria, which are, really important to the identification of IBS for clinical trials. But the Rome criteria, in the spirit of the Rome criteria, and actually literally in black and white, the Rome criteria in its original format was a diagnosis of exclusion. So after the doctor does all the workup and they feel like they ruled everything else out, then you can apply the Rome criteria. And that was the spirit of the Rome criteria in the beginning. Now, data more recently says, well, maybe you can use the Rome criteria without doing an extensive workup. But the point is the patient still feels like it's simply a criteria. But I do, and I say this quite often, but I haven't said this lately, it is a little insulting to patients to be called irritable, to be called a bowel, and to be called a syndrome, which means that the disease or the condition is not verified as a disease. So it's a syndrome, it's a constellation of symptoms, and therefore not really legitimate or legitimized by an organic illness or a true cause. So we know stress affects the motility of the gut. We know when people are acutely stressed, they can have diarrhea. I'm not disputing those terms, but the question is, does stress cause IBS? So in other words, if you had a stressful event in your life and it's gone, do you now have IBS for the rest of your life? And there's never been a true controlled trial to prove that. It's always been comparing IBS to healthy people. Well, healthy people don't have anything, so you're going to see differences. But this study that I'm going to show you here from 2013 looked at the deployment of military to combat zones within the world during the Iraq War. And they looked at military personnel deployed, and they came back from deployment with IBS. Not all of them, but a good percentage of them, and they didn't have it before they were deployed. So they looked at whether they were in combat or experiencing life traumatic events that most people wouldn't ordinarily experience, and yet it didn't precipitate IBS or wasn't associated. The only thing that they found in this study that precipitated or was associated with the development of IBS was they got food poisoning that was documented during their deployment. So this is truly the best study there is on studying people prospectively in a large scale. I believe there was 10 or 20,000 people followed during this trial. And so this is proof that stress is not a contributor to IBS, but is also proof that food poisoning is. And so let's continue so as we unfold this, but hold this thought because we'll get back to it as we try to understand this pathophysiology. But the spoiler is that I show this slide now all the time, so if you've seen it, I apologize for showing it again, but this is really our map to the development of IBS. That food poisoning on the left through a toxin called CdtB and the development of an autoantibody to vinculin damages the nerves of the gut, leading to poor flow of the gut and then bacterial buildup, and that makes it IBS an antibiotic responsive disease. Okay. So we talk about bacterial overgrowth here, but what is bacterial overgrowth? So the large intestine, half the weight of stool is bacteria. The small intestine contains very little bacteria. In fact, we now have new definitions based on the North American consensus, and more recently I published the SIBO guideline document, which is a template to suggest that 10 to the 3 really is the cutoff, or greater than 1,000 bacteria per milliliter is the cutoff for small bowel fluid based on the evidence. Now this gets confusing for the audience and for doctors even, because it's a little hard to understand. Do I have SIBO or do I have IBS, or do I have both? So I want you to reflect back on H. pylori as a cause of ulcers. So there was a term in the 1980s called peptic ulcer disease. You scope because somebody's bleeding or having pain in their stomach and you find an ulcer in the stomach. What we soon learned in the 1980s, another Australian discovered that H. pylori was the cause of ulcers, but it wasn't the cause of all ulcers, maybe 60 or 70% of ulcers. Huge discovery. But the term peptic ulcer disease is still what we call peptic ulcer disease. We just now know that H. pylori is a cause of a percentage of peptic ulcer disease. I reflect on that because I think this is a similar situation. It's irritable bowel syndrome, and of irritable bowel syndrome patients, about 60 or 70% are associated with small intestinal bacterial overgrowth, and treating that makes them better. But remember, there are H. pylori patients who don't have ulcers, and there are SIBO patients who don't have IBS. So you could have adhesions that cause IBS, or SIBO. You could have pancreas insufficiency that can cause bacterial overgrowth. And there's a long list of things that can cause overgrowth, but are not IBS. So it's a similar story as the H. pylori story. To diagnose overgrowth, traditionally we've used breath testing, because breath testing is relatively easy and straightforward. So you ingest a carbohydrate, in most cases it's lactulose, but some people also use glucose. It gets into the stomach. It goes into the small intestine where the bacteria should not be, but they are in this case, and they ferment, produce the gases, and then it's expelled in your breath to be found in your breath, and then you're able to do the breath test and say you have bacterial overgrowth. But there's been some criticism about breath testing, but I think this sort of settles it. So this is a paper. It's Australian night, so Nick Towley is part of this paper, who's a prominent investigator in Australia. And this is pretty much the defining study of the last 10 years in the sense that it summarizes everything that we've been saying for 20 years and proves it. So this is a meta-analysis of 25 studies over 6,000 patients. And the conclusion is SIBO is more prevalent in IBS than healthy controls, period. And that is now a true statement based on breath test. Second statement is culture of greater than 10 to the 3 shows SIBO by culture is more common in IBS than healthy people. So even culture proves that SIBO is in IBS, and that methane on breath test is associated with constipation. And so this study really is like a capstone to 20 years of research because it finally proves, yes, SIBO and IBS are together. And this is the long form of this description of the meta-analysis. And you can see that I only have one paper here, so this isn't a Pimentel effect of our study weighing in on this because there's 25 studies here. Now, breath testing is complicated because we originally had a breath test just measuring hydrogen, but hydrogen is just a fuel because methane producers use 4 hydrogens to produce 1 methane, and we now know methane causes the constipation side of overgrowth, and that hydrogen sulfide producers are the diarrhea side, although we don't have this breath test yet, the 3-gas breath test, which is coming soon, but hydrogen sulfide produces diarrhea. Interestingly, you can consider the hydrogen the rabbits, and the methane producers the foxes, the hydrogen sulfide produces the wolves. So when you have rabbits, either the wolves win or the foxes win, and that will determine what your symptoms are in general. This is the same meta-analysis for Nictali, showing that methane is associated with constipation. But the important thing is the new North American consensus, the new SIBO guidelines from the American College of Gastroenterology have changed the name. It's not methane SIBO anymore. It's now called intestinal methanogen overgrowth because methane bugs or organisms are not bacteria. So you can't call it SIBO because the B stands for bacteria. So we're calling it IMO, or intestinal methanogen overgrowth. But it leads to the prospect of antibiotics. So if you have too much bacteria in the gut, could you take an antibiotic? And we now know based on FDA approval for rifaximin for irritable bowel syndrome, the rifaximin treats IBS on the basis that IBS is a bacterial disease. Not only does it treat it, but 2 weeks of this antibiotic leads to 3 months of benefit. And this is a very important study. Again, this is not in press now. I should say it's published because it was in the Red Journal just before the holidays, so in the last part of 2019. This is a very important study because for the first time in a very large scale study, they did a subset of breath tests, and they found that, sure, if you took rifaximin, 44% of you would get better without knowing anything. But if your breath test was negative, you're much less likely to respond to rifaximin than if your breath test was positive, where it's 56%. And if your breath test was positive and then became negative, 76% of people met the very challenging FDA endpoint. Again, supporting the notion that the breath test predicts who has overgrowth and who will respond to rifaximin among IBS patients. Okay, well now let's get to how this all happens. What is the origin of all of this mess of bacterial overgrowth and so forth? And it leads back to food poisoning, and that's what we're here to talk about anyways today. Food poisoning as a cause of IBS. Well, here's another capstone meta-analysis or capstone study, because this is the definitive study, 45 outbreaks followed with time, and 11% of people. So if you infected 100 people with Salmonella or Campylobacter food poisoning, 11% would walk out the back end of that food poisoning with IBS. And this study basically says food poisoning causes IBS. Full stop, period, that's it. We now know that. And so in 2020, we can say definitively that we know more about what causes IBS than we do Crohn's or ulcerative colitis, because we still don't know what triggers Crohn's or ulcerative colitis, but food poisoning triggers IBS. So what are the risk factors? Well, the risk factors are the sicker you are during food poisoning, the more likely you are to develop IBS. If you're a woman, you're more likely to develop IBS. Now, that may be why more women have IBS. But women get more autoimmune disease, and we're going to talk about those autoimmune markers here in a minute. And so maybe that's why women are more susceptible, but we still don't understand the genetics of why that is. Blood in the stool, you need antibiotics, you got to be admitted to hospital. All those things would make you develop IBS more likely. Well, if you want to figure out this story now, you have to develop animal models. So we developed an animal model, this time using food poisoning. That's Campylobacter, which is the #1 cause of bacterial gastroenteritis in the United States. And I believe it's similar in Australia. And we gave Campylobacter to half of our rats. The other half, we gave them placebo. And then we let them recover. And then they hung around for another 3 months because now they're post-infectious. And then we were able to see that some of them had weird stool after the Campylobacter, and then we did bacterial quantitation, and we found that 27% of the rats who got Campylobacter now have bacterial overgrowth. So for the first time in history, a study shows that, just like humans, food poisoning causes IBS, and we know IBS is associated with overgrowth, and in rats, food poisoning of rats causes overgrowth, but also IBS because they got weird stool forms. So if you look at the pink column, Campylobacter treated now have bacterial overgrowth. 80+% of these rats had weird stool form and increased rectal lymphocytes, which is a type of white blood cell that is indicating chronic inflammation in the rectum. And this is the only thing seen in humans with post-infectious IBS. Up to the point of this trial. So we know that Shigella can cause IBS, Salmonella can cause IBS, Campylobacter, E. coli, they're all food poisoning pathogens. But what do they have in common? And they have really only one toxin in common, and that's cytolethal distending toxin B. B is the active component of that toxin. So we repeated the experiment. This time we created a Campylobacter missing this toxin, doesn't have this toxin. We have wild type, regular, plain old Campylobacter on the left. We have Campylobacter that's been modified so it doesn't produce the toxin. And then we do a trick where we say, okay, let's say you're going somewhere where food poisoning is common, and you take rifaximin or an antibiotic every day to prevent food poisoning. So if you don't get food poisoning, maybe you don't get IBS. And the most important finding here is if you don't have CdtB, you don't develop IBS. And this is what it looks like in the raw data. But suffice to say, if you took rifaximin every day in a place where there's food poisoning, you probably don't get infected and you don't get IBS. If you don't have CdtB toxin, it's statistically significantly less IBS versus the Campylobacter alone. So this is a colorful slide here. This is the cleaning wave of your gut. So when you wake up in the morning, you go to work, you forgot, didn't have time to eat breakfast, and your stomach is gurgling, and you're saying, oh boy, I'm hungry, I should eat because everybody can hear my stomach. That's this wave coming through the entire small bowel to clean up. It's like a dishwasher. So every time you're fasting or through the night, every 90 minutes, this dishwasher comes through the intestine to clean up all the pieces of lettuce and junk that you haven't been able to digest, because humans don't digest those things, to keep the dish clean. So it's like you put your dish in the dishwasher, you wash it in the morning, you take it out, it's all clean, ready for breakfast. It's been known since 1978, if this dishwasher doesn't work or this cleaning wave doesn't work, you get bacterial overgrowth. Well, there are special cells that make this wave happen. They're called ICC cells. And we now know from the Campylobacter experiment that Campylobacter makes these ICC cells that drive this wave go down. But the ultimate experiment is this. So if food poisoning causes IBS because of CdtB, then you don't need food poisoning. All you need is CdtB. So what we did here was we took the toxin, purified it, and we injected it into the arm of rats. And then we saw, of course, they developed antibodies to CdtB because it's a foreign protein, but they also developed antibodies to a protein called vinculin. And this took 3 or 4 years to figure out. It's a very long and drawn out process, and I can't show you all the slides because we'd be here for hours. But the point is, the vinculin antibodies develop as well. So again, just to reiterate, we inject the rats with CdtB and they develop antibodies to you, a protein on you called vinculin, which is important for nerves to stick together in the gut. Not only that, the higher the antibody to CdtB was, the more bacteria you had in the duodenum, the more bacteria you had in the ileum, meaning you developed overgrowth, and the less vinculin was in the gut wall because it was sopping up the vinculin. And the weirder your stool was, the more the anti-CdtB was elevated. So the point is, just the CdtB alone created altered bowel pattern, overgrowth, and all the things we saw with Campylobacter. So what is vinculin? So if you look here, you've got these green filaments in a cell, which is the skeleton of the cell holding the cell's shape. At the end are tufts of vinculin, this red part. And vinculin is like a motor at the end of actin going along that line or chain of actin, making the cells reach out like they're, you can see them reaching out here, and then they grab onto the cell next to them and then they stick to them. And that's how nerves connect. And in the gut, the cells that we were talking about earlier have the type of vinculin for which the antibody forms here. So it's like this. You get an infection, you get exposed to this toxin on the left, CdtB, you form antibodies to it because it's not you, so you form an antibody to different parts, but one part looks like vinculin, and so you develop what's called autoimmunity. So now that we know this, could we measure these two antibodies and diagnose IBS? So we did a very large study of 2,300 patients. I'm not going to show you that. I'm going to show you the second generation test, which is much more accurate. And we're going to, we measured these antibodies, anti-CdtB and anti-vinculin, and compared this to people with Crohn's disease or ulcerative colitis. So the orange column is IBS for anti-CdtB, anti-vinculin, and these columns are inflammatory bowel disease in general, ulcerative colitis, and Crohn's disease. So what we showed is that these antibodies are elevated in IBS, but they're not elevated in these other inflammatory conditions. But it also gave us a very, very good post-test probability, and I'll show you that on the next slide in graphic form, and a very high specificity. Now, some people say, well, the sensitivity is low. It has to be low because, first of all, we want the specificity to be high, so you set the cutoff of the test to be very specific for IBS, so people stop doing colonoscopies unnecessarily. Secondly, only 60% of IBS is post-infectious or SIBO. So you can't even get a sensitivity more than 60 because only 60% of the 100 people with IBS you test are potentially positive. So this is really nothing to be worried about is what I'm saying. But I want you to focus on this. This is the likelihood ratio. So this is the most important factor here. The likelihood ratio of 6.3 and 5.3 are very good for a test. And how do you use that? So Alex Ford published a paper, said that a good gastroenterologist, after seeing a patient, has a pretty good idea that it's IBS. Let's say their post-test, after seeing the gastroenterologist, their accuracy is about 56%. If you then pass this line through the 6.3 I told you about on the last slide, that gives you a post-test probability of IBS of about 90. But if both tests are positive, you get to 98% post-test probability. If both tests are negative, it drops to 22% post-test probability. So in other words, a negative test is also valuable because you're less likely to have IBS and you should look for other things. A positive test gives you a very strong confidence that you have IBS. Now the gray is medical certainty. So there was a study that looked at all tests that were available for IBS. And so we go back to this nomogram, we go back to medical certainty, and we look at everything that's ever been looked at for IBS. So some people used to think that, if you do a colonoscopy and you feel pain, that's a good indicator of IBS. Well, remember, 56% is what Ford says, and it actually makes it worse. It doesn't really diagnose IBS, no better than what we already knew. There was a 34 biomarker panel that will get you to 74% post-test probability. Bile acids in stool will get you to 78. There was a 10 biomarker panel that will get you to 79. Visceral hyperalgesia is you put a balloon in the rectum, you inflate it, and patients with IBS have more pain at lower volume. So that was in the medical certainty range, but kind of invasive. So volatiles in the stool gets you to 86. This is volatiles that look at, bacterial products, again, suggesting this is a bacterial disease anyway. But anti-vinculin is 87, anti-CdtB is 89, and both together are 98. So we're getting to medical certainty with the two best tests that are out there, which is anti-CdtB and anti-vinculin. This is a really important study that was published. It's not really a study, it's a case report, because so this patient went to Mexico City, got diarrhea, came back still suffering. Now it's 8 weeks later, still severe bloating. And this is what happens with the antibodies. So anti-CdtB is up right away within 8 weeks. But anti-vinculin down here is still normal and doesn't reach abnormal until 12 weeks. So you start with CdtB, you later develop anti-vinculin over time. And that's what we see clinically. So this is sort of a template of how we now think the test is working. So if you're low for both, well, you either don't have IBS, you should be looking for something else, meaning the post-test probability, which I showed you, goes down to 22%. So you need to look for something else just in case. Still could be IBS of another reason, but it's not post-infectious. If anti-CdtB is high, you could have had a recent infection that was driving this, and that's what's happening. And, or you do not develop autoimmunity, and I'll show you a case which illustrates that. If anti-CdtB is low, anti-vinculin is high, then the infection was long ago, no more CdtB, those antibodies have slowly gone down, but you're now autoimmune to yourself. If both are high, it's a recent infection. It's sort of like this case here where both are high at 12 weeks after infection. That's possible. And then we see anti-vinculin super high, and these are the sickest patients we have. So we actually feel like anti-vinculin, now having run these tests for a while, is proportional. So these patients really have a motility disorder because of it. Yes, they have overgrowth because the motility disorder is so significant. And you treat the overgrowth, but they're more likely to need prokinetics or other things. So let me tell you 3 cases, and then we'll go to the summary of all this. Case 1 is a 35-year-old male, swam in their neighbor's pool and developed gastroenteritis. Now, this neighbor's pool wasn't filtered. He didn't know that. And then has had IBS since then. So we measured the antibody, and his anti-CdtB was super high, 3.06. But vinculin was normal. So he didn't develop autoimmunity, at least not at that point. And he was treated with rifaximin. He was having recurrences. We treated him with peppermint oil and a number of other things, and he was doing okay, sort of getting by. And then we measured his antibody again. And then in December, I saw him, and I said, "How are you doing?" He says, "I'm doing great." I said, "What do you mean?" He said, "Well, I'm taking nothing. I'm not on any medication whatsoever." And I said, "For how long?" He says, "For 6 months." So we remeasured the antibody, and the antibody was basically gone. So his CdtB disappeared. So we've seen this a few times, that if you don't develop the autoimmunity and you don't get food poisoning again, eventually the antibodies disappear. And I think that's a very interesting result. And I actually like when patients are CdtB positive, because I think if they don't get food poisoning again, they could remit. And if you go back to the outbreaks in that big Mayo Clinic study, some of the patients never remitted. So people got food poisoning, they developed IBS, and about half of them, it disappeared over 4 or 5, 8 years, depending upon which study and how long they followed them. So this may be that patient or the patients who had this antibody profile. The second case is a 20-year-old man. The patient was a usual state of health until a year ago, no gastroenteritis. So remember, if a patient comes to my clinic with diarrhea, that's the patient I do the antibodies on, because they may not remember the food poisoning. Obviously, if somebody comes to your office and say, "Look, I had food poisoning 6 months ago, and now I have all this problem," it becomes more obvious to do the test. But I do it in my patients with chronic diarrhea, and if it's positive, then I know. But look at this. This patient had a colonoscopy, ultrasound, stool studies, all negative. CBC, chem panel, celiac testing, and fecal calprotectin, all negative. And then we did this test, and his anti-vinculin was positive at 1.63. Anti-CdtB was negative. So clearly has IBS, post-infectious IBS, because the antibodies are positive. Now, in the family history, I happen to see his mother. And his mother is quite sick with this, with these super high vinculin antibodies, and she needs a lot of treatment and a lot of care because she's much more affected. So I'm thinking to myself, okay, if the mother is this sick and his anti-vinculin is 1.63, I can't let him get like her, because if he gets another food poisoning, he's going to have it even higher and higher and eventually become more difficult to treat. And interestingly, we gave him rifaximin. He responded brilliantly, 90% improved, and it's now 6 months later, and he's still feeling great because this antibody isn't all that high. Contrast that with his mother, who needs rifaximin, half a pill every day to keep the overgrowth away. And she's one of the few patients I have in my clinic where I need to use chronic therapy. I know it's not the typical therapy that's approved by the FDA for IBS, but that's the only way she stays well. So same young man could have saved, at least in American dollars and an American system, between $2,000 and $4,000 if none of this testing had been done, and we'd have gone straight to the anti-vinculin and anti-CdtB test or the IBS-SMart test. Well, so cost savings would have been a big thing for this young person. I told you what I did for treatment, told you about the family history, but now he wants to go to Southeast Asia, to some rural areas in December. That's this year in 2020. And he asked me, what should I do? And so what I am doing, and again, it's not FDA approved to use this way, but I'm giving rifaximin based on that animal study prophylactically. So he'll take a little bit of rifaximin, half a pill with each meal, and we can prevent food poisoning. And that there is a study in humans that it does work that way based on a study from Texas. So we don't want those antibodies to go higher, and he needs to practice good, careful eating habits when he travels. The third case is a young woman who presents with diarrhea, seen by at least one outside GI doctor, no blood, no red flag symptoms. It started over a year ago. It still has diarrhea. Calprotectin's normal. CT abdomen, I'm not sure why somebody did that, but that was normal. And so I was going to, do I treat her? Does she have IBS? Do I need to do further tests? Her mother wanted to do a colonoscopy. She has no history of travel or food poisoning. She meets the Rome criteria for IBS. And then again, we did some stool studies just to be sure she doesn't have anything going on, and that's all normal. But her antibodies now, we got them back, and they're negative. So she has nothing. She doesn't have anti-vinculin, and she doesn't have anti-CdtB. So I said, well, I guess we need to do a colonoscopy. So we did a colonoscopy, and we looked for celiac disease, and she doesn't have celiac disease. So the biopsies were normal and of the duodenum. But on colonoscopy, she had microscopic colitis. So the diagnosis here is microscopic colitis, and she needed to get treatment. So we come back to the final story here, which is, after all of what I've told you, this is the path that you develop. You have to have food poisoning, you have these antibodies to CdtB, antibodies to vinculin, and the profiles of those can give you some good information about what's going on with the patient. You get a reduction in these nerve cells, you get bacterial overgrowth because of the lack of flow of the gut, and then IBS is an antibiotic responsive disease. So in summary, these are the tests that are available or were available. Rome criteria are easy, but they don't tell you what caused IBS. They don't have any specificity, but 70% of Crohn's patients meet Rome criteria, so that's not helpful. Genetics, there was genetic testing, but really were not very specific, and so they've been removed from the market in the US. Fecal calprotectin, sure, if it's positive, maybe you have Crohn's, maybe you have ulcerative colitis, but if you're negative, you're still scratching your head, and sure, it certainly doesn't tell the patient why they have IBS. It doesn't even tell them they have IBS, because it's not a test for IBS, it's a test for inflammation. Breath testing can be helpful because it can tell you that how to treat the patient. Maybe if you're methane, you take a certain treatment. If you're hydrogen, you take another treatment. And then finally, IBS-SMART is sort of checks all the boxes because it's easy, it's just blood, high specificity, and I told you it's over 90%. It's a diagnosis of inclusion. So for the first time, we can tell IBS patients, okay, you have IBS. It's real, it's not in your head. Here's the test that proves it. It's from food poisoning, we know that, so that's the pathophysiology of it. And it can guide therapy. I just told you that if certain tests are positive or abnormal, I'm changing the way I'm speaking to the patient, telling them to avoid food poisoning, maybe even prophylaxing them with travel. It reduces costs, and there's a cost analysis that's going to be published later this year that shows how much it reduces cost, and it reduces costs in multiple countries in the modeling, and it's available. So in sort of finally, anti-vinculin and anti-CdtB are important to test because, number one, they save costs. Number two, they validate the patient, and the patient feels confident that they finally have a diagnosis. They know that food poisoning was the cause, and we may be provided opportunities from preventing patients from being worse off if they get further food poisoning because they now know what they have. So that was all I was going to say today, and I look forward to any of your questions at this point.
Great. Thank you so much, Dr. Pimentel. I hope you can hear me.
Yes.
Yeah, great. Thank you. That was really very informative. And, you know, I was going to sort of talk about the IBS-SMART and how to order it right now, but I think due to your busy day, I think we'll just get to the questions right now. And just participants, if you could put your questions into the Q&A. If you click on the little Q&A box down there, you can put your questions, and I will read them out to Dr. Pimentel. But I can start it off because there were a few things that you said that were really interesting and new. Like, for example, the whole EMO, that I'm very happy to hear that EMO is a thing now, or intestinal methanogen overgrowth. So that's finally happened. For those of you who have heard me talk about this, methanogen overgrowth can also happen in the large intestine, and so often it's a very confusing picture with constipation. But back to the IBS-SMART. So one of the slides you talked about how when CdtB is elevated but vinculin is negative, that may not actually be a cause or a time to prescribe prokinetics. Did I get that correct?
So it's more that, I mean, if it were me who had IBS, I would be more happy if I had CdtB positive and not vinculin, because I think, knowing what I know now, that patients avoiding food poisoning, their symptoms will gradually change over time. That's what I think. But you know, a prokinetic could still be useful. It depends on how the patients respond. But my experience is that patients with just CdtB seem to respond just to antibiotics and may not need prokinetics. But we need more experience with the test to know that for sure.
Great. First question is there any point EMO people getting this test?
So we don't see a lot of positive. So we think EMO is different. It's not necessarily post-infectious. So if you took 100 people with IBS with diarrhea or mixed, between 40 and 70% would be positive on this test. If you took EMO patients or people with methanogen overgrowth, only about 25% would be positive. So it's less helpful. And in fact, in the studies that I was summarizing, constipation is a less common outcome of food poisoning. So I sort of think of methane overgrowth or methanogen overgrowth as different than the food poisoning derived sort of causes of IBS on the other side.
Okay, I think you've answered a few of the people's question about confirming IBS-SMART to be used for IBS-C or just IBS-D, and I think IBS-D is definitely a priority there. Another question is, what is the incidence of comorbidities with a positive IBS-SMART test, i.e., can you rule out IBD if the IBS-SMART test is positive, or can more serious conditions such as bowel cancer, IBS, coexist with a positive IBS-SMART test?
Well, I mean, I think we need to practice as we practice based on guidelines. So in other words, if you're at least in the US now, over 45. In other countries, it's over 50. Screening for colon cancer is required, or at least recommended. So I don't think this changes that. I think the question is, so let's say you have a patient with diarrhea in your clinic, and you have a positive anti-CdtB and anti-vinculin, then you more than likely have IBS by a strong margin, because very few IBD patients have this. But remember, a certain percentage of all patients have IBS. So a certain percentage of lupus patients have IBS, a certain percentage of Crohn's patients might have IBS overlap. But I would say it's, based on our data, I think it's less than 5% of Crohn's patients will have a positive test. So probably those have IBS as well. But 60 to 70% of IBS patients are positive. So it's a stark difference.
Great. What is the treatment when someone has high vinculin, low CdtB, and they're having severe diarrhea again suddenly? What is the preferred treatment?
So we generally, we start with rifaximin. Obviously, there are other over-the-counter or even natural therapies that are available, and I think it's beyond the scope of this conversation to get into all of that. But I think if the anti-vinculin is very high, if you can get them down, the diarrhea down, then I would start a prokinetic. That's what I do in my clinic. So either low-dose erythromycin. Some people use low-dose naltrexone, both for anti-inflammatory and prokinetic. But we're also using a lot more prucalopride now. I'm in Australia. At low dose, again, 0.5 milligram at bedtime for all these prokinetics.
And are there any specific diet changes to make between positive result and, say, SIBO or IBS not positive? I'm not sure I understand this, Lisa. Maybe I move on. Maybe clarify a bit more, Lisa, on that question. Okay, next question is, have you used probiotics, e.g. Saccharomyces or Travelan, which is a colostrum that prevents traveler's diarrhea, in the prevention of TD or traveler's diarrhea for those who may be susceptible to autoimmunity?
Yeah, sorry, it's a great question.
Yeah, go ahead.
I haven't. It's an interesting point. I'd be curious to see if patients or people have that experience over the next year, if people start doing the tests and exploring those. But I don't have experience using those.
Okay. I usually use things like berberine, and I do use Saccharomyces also because it tends to increase secretory IgA and stuff. But, you know, that's sort of case-by-case basis. My big question is about how do you, so I have two questions. One is, my initial sort of assumption when the IBS-SMART first came out was that you only ever need to test one, but in your, one time to see if they're positive or negative. But in your, as time has gone on, it looks like you have tested people repeatedly to see what these antibodies are doing. So how do you retest, I guess, is my question, or when would you retest a patient?
So we're collecting data on all of these patients, and over time we'll continue to publish iterations of what to do. But here's what I can tell you for fact. If you test the antibodies, and let's say you give rifaximin, and then you test them again 2 weeks later, nothing will change with those. They don't shift because, depending upon whether you respond to rifaximin, these are antibodies, they're going to be stable in your blood over months or years. The CdtB antibody is an antibody to, let's say you were to get tetanus vaccine. You have to get it every 10 years because the antibodies wear out. If you don't get tetanus, you don't get the antibodies to continue, so they eventually diminish. And I think that's the same thing here. If you get CdtB antibodies, if you don't get food poisoning again, eventually the CdtB antibodies diminish and your symptoms get better. But the vinculin is autoimmune. You can't get rid of your vinculin in your body. You keep producing it. So it's probably fueling the ongoing nature of it. So I guess to answer the question more definitively, I wouldn't order it more than at least, more frequently than every 6 months or every year, because I don't think it will change that much. But if you're interested in seeing the evolution of it in a patient, then that's what I do. I'm probably making it once a year now, just to see if they're going up or down, because the problem with the antibodies is they move. So let's say you had food poisoning 2 months ago. Well, if you measure it now, it's going to be one way, but 2 months from now, it may be different because of what I said about vinculin. It comes at 3 months. So if you know when the food poisoning occurred, you may need to measure it more closely together. But if they're established patient, then once a year is plenty. I know I went all over the place with that, but I think I myself clear.
Okay. Great. Okay, my camera just came on. Excellent. Okay, another question I had about breath testing. A lot of people are going to ask, does this take the place of breath testing?
So I look at it as complementary, because the thing is, you can have overgrowth, but why do you have overgrowth? I always want to know the why, because it helps the patient. If the patient has negative antibodies and overgrowth, then maybe it's caused by adhesions. Maybe I need to do a different kind of workup for that patient. If they have overgrowth and positive antibodies, then it's food poisoning related. So, look, I mean, my job is to find out what the patient has and why. And the patient has overgrowth, and why they have overgrowth is food poisoning and these antibodies, and then I can protect them from getting further food poisoning and take different precautions depending upon the two partner tests.
What I've been telling people is, and correct me if I'm wrong, but I think of the IBS-SMART really just a test for the underlying cause, but not necessarily the severity of the overgrowth, because that can't really be measured with that. So it's really finding the underlying cause to their SIBO, which is so important to prevent relapse with the proper medication.
I agree. I think that's the right way to use it.
Okay, a couple more questions. How are we defining diarrhea? Can we tell if it is overflow as opposed to diarrhea? And do we think of loose stools as diarrhea or just watery diarrhea?
Well, that's a whole diarrhea question, because there's many reasons for diarrhea. Overflow can be a cause of diarrhea if you're very constipated. Usually those are nursing home patients, but there are patients who are walking around like that. But in general, when we talk about diarrhea, in terms of IBS, someday they're constipated, someday diarrhea. IBS diarrhea tends to be all over the map, very, very different day by day. If somebody comes in with 10 watery bowel movements a day, I can tell you for a fact they probably don't have IBS anyway, because IBS never presents with that kind of vigorous watery bowel movement. But I can get into more details about diarrhea.
You've got lives to save out there. Yeah, I'm trying to speed this up for you so that you can get back to preparing your hospital for a pandemic. But I think for how I would think about that is when somebody comes in with these different symptoms that I would think of as SIBO IBS, I would do a breath test, and if they're positive, I usually start there, and if they're positive, then I would consider doing this anti-vinculin antibody test, because do you think that's the proper sort of sequence, or would you do it the other way around?
I don't think it matters which way around you do it. I tend to do both so I can get the most information possible. I mean, I really want to know, is food poisoning the cause? And that gives the patient, because, look, even if you did SIBO, right, and you got a SIBO positive test, the patient's still saying, well, how the heck did I get this? Why do I have this? And this will give at least some information about why this is happening to them.
Okay, great. Okay, I think there's more clarification about that question with the diet. I think it has to do with autoimmunity and diet. So positive for IBS-SMART test patients or patients with SIBO or IBS, but not positive to IBS-SMART. Any different diet recommendation? I'm assuming it relates to the autoimmune component, if you would change any part of the diet.
So we've only had this test for a little while, so it's hard to know how diet influences the test or vice versa? It's a great question. Whoever is asking that question, if you do some tests and you figure something out, let me know. But I haven't been able to pin something down like that, not yet anyway.
Couple more. Are there any types of SIBO that could be missed with this test? Great question.
So the test is not going to tell you what type of SIBO you have. At least we don't think so yet. No, we don't have the hydrogen sulfide available yet, which is coming. So maybe it'll help with that. So the jury's still out on that. But generally, if you're methane positive on your breath test and you're constipated, I don't see the need to do this test. I'm not sure it's going to be valuable, especially if they're constipated, because the likelihood of it being positive is lower. But definitely for your diarrhea patients, I mean, I do it for all my diarrhea patients now.
Great. I did have a patient anyways, we'll move on, but it was a microcytic or microscopic colitis patient after all, and not a SIBO patient. But last question on my part is that there are other tests out there that are touting this this particular panel or this test. Can you briefly talk about that, the lookalikes that are out there?
Well, I mean, they're calling themselves by different names, but the point is, this is the original test. This is the test that's validated in publication. And the second part of it is this second generation test, which is IBS-SMART. There's a problem with the antigens, so CdtB and vinculin. So what we did in this to make it better than the original test is epitope optimization. So the proteins are unstable, and we figured out a way to stabilize the proteins so that the test would even behave better. And that's how we got such high specificities. And so it works much better than the original. So whatever you want to call them, knockoffs or whatever they are, they're not the test that was in these publications, and they're certainly not the epitope optimization for ideal characteristics. So I don't know what they are, to be honest.
Okay. All right. But this one, the IBS-SMART, I think is FDA approved, right? So yeah.
FDA allows what's called lab-directed tests run by CLIA-certified laboratories. And so this is an allowed test under the laws of the United States as a lab-directed test.
Great. I think that was it. The rest is the other questions really relate to the logistics of ordering the test. I think there was one last one squeezing in. I noticed that you're only seeming to use rifaximin. Do you also use neomycin for treatment too? Remembering that this is diarrhea dominant or usually hydrogen dominant SIBO. So that's usually just a rifaximin based treatment, unless you want to comment on that, Dr. Pimentel.
I think neomycin is less used in the diarrhea side. More we combine it with rifaximin for the methane or constipated side. So the question is a good question, but we use neomycin with rifaximin more on the methane constipated patient.
Great. Well, I think that answers all of the questions that have come through. Participants, please stay on the webinar so that we can walk you through the cost of the test, how to order the test, etc. So, but really, thank you so much for your time in these really crazy times that we are living in, and I wish you all the best and stay healthy. Please stay healthy, and yeah, and really thanks again, and I'm sure we will talk again at some point.
Well, thank you very much, and nice to talk to you all, and same thing to you. Be healthy.